Good evening, everybody. I am Rahul Chobe from Physio TV. We are live now. I am handing over the session to Dr. Siddhant, who will introduce the speaker and the panelist. Over to you, Dr. Siddhant.
Thank you so much, Mr. Chobe. Good evening, everyone, and welcome to today's Physio TV session. Today, we have a very interesting topic titled Breaking Down Stride, Analyzing Runners Effectively. On the panel, we have our very own Dr. Anand Gangwal, sir. He is Director for Prime Physio Pune and Associate Professor and Postgraduate Guide at Sancheti College of Physiotherapy, with an experience of various sports clinics in Australia as well as Spain. He holds a degree in Masters in Orthopaedics, Sports and Manual Therapy, University of South Australia. He is indeed our in-house Iron Man, as we like to call him, as he holds the title as well. So I would request Dr. Anand Gangwal, sir, to please introduce our speaker for the day.
Thank you, Siddhant. It's really a privilege to introduce Dr. Annie. She's a physical therapist and orthopedic clinical specialist. She's currently the running and biomotion specialist at the Sinai Rehabilitation Center in Baltimore. Dr. Annie earned her bachelor's degree in exercise science from the University of South Carolina and her doctorate from physical therapy from the University of Maryland, Baltimore. She specializes in the evaluation and treatment of both non-operative and post-operative orthopedic and sports conditions. She's an avid runner herself, having completed 7 marathons, and often can be found running around Baltimore City with the most faithful training partner, her dog Adler. Over to you, Annie.
Thank you both so much for your introduction. I'm excited to take part in this, and I'm excited for you guys to have me on. If you guys have any issues with the videos or the screen, please let me know. But yes, so my name is Dr. Grace, or I actually go by Annie Neurohr, and I am a doctor of physical therapy, a clinical orthopedic specialist, and I am the running and biomotion specialist at the Rubin Institute out of Sinai Hospital in Baltimore, Maryland. So a quick little bit about me. Here we go. So all in pictures. So this is my group here at Sinai Hospital. A couple of our therapists make up a really, really good team. I'm very grateful to work alongside some brilliant physical therapists, physicians, rehab techs. So that's kind of our gym setup here with some of our current therapists and techs. I may look familiar to some of you because I was actually in Pune at Sancheti about a year ago, and I wish greatly that I was doing this in real time versus Zoom, but we'll make what we have to make work. So this was a picture from our last trip to Sancheti, which was just an amazing experience. Other things I do, I hold running clinics for local colleges and schools, breaking down their forms and giving them some feedback for their cross-country and distant track stars or runners. I'm also the founder and director of an organization, not the organization, but the running clinic for an organization called Back on My Feet, which is a running group formed for members who are dealing with addiction issues and homelessness. And I help basically direct their running clinic and their injury prevention clinic with 2 other therapists here, Allie and Jenna, who also volunteer their time. So I'm grateful to have them with me as well. And like I said, I'm a pretty avid runner myself. I love running. I've been running for a really long time now, and I love working with runners. So that's what kind of prompted me to want to do this lecture and take part in this content. So when I evaluate runners, what I typically do is I try to break everything down in a what, why, how, or if approach. And I think that a lot of times as physical therapists, especially as new therapists, if you're not seeing runners constantly, it's really easy to get overwhelmed by gait analysis and to think that you need to understand and see all of the deficits and know what's happening and why it's happening and be able to fix it right away, which is never really the case, at least for me. And I've been doing this for a few years now. What we're going to focus on today with this part of the lecture is the what. So the what are you seeing when you're breaking down running analysis? I'll have to talk with Sona about maybe doing a couple other lectures later on about the why and the how. But today I really wanted to focus on the what. So what you see and what to look for when you're actually analyzing runners, so that we can basically simplify this and take it as almost a strategy or an algorithm versus just blindly watching someone run, hoping that you'll be able to figure out what's going on, but not really having any real strategy. First of all, you want to get the perfect shot. So for video gait analysis, you want to be able to have all planes seen. You want to be able to see the entire person in the frame. Some of my videos, you won't see the entire person. That's mostly for privacy reasons. But when I actually film them and analyze them, you want to see everything from head to toe. And you want to see them from frontal view, from the front and from behind. And you want to see them from the sagittal view, both sides as well. Here's a little quick look at kind of the setup. So for the runner, they need to be wearing tight clothing. No shirt is preferable. For women, you really want them in shorts rather than leggings. So you want to be able to see their knees. And in these photos, we actually have some of the 3D analysis orbs on them. You don't need those, but they can be helpful to give you kind of, when you're doing a 2D analysis with a video, to give you some marker placements and know exactly where these landmarks, these bony landmarks are in space, so that you're doing as little guessing as possible when you're going back through the video. So that's kind of the setup of what you want your patient to look like before they get on the treadmill. What I typically do is I give my runners 3 to 6 minutes of an acclimation period. So they need to be on the treadmill, jogging, warming up for at least 3 minutes. Some of the research has shown that it takes about 3 minutes for someone who's normally used to running outside to get acclimated and accustomed to a treadmill, and that their gait will pretty much normalize to what they would do once they're in stride outside over ground, even though they're now on the treadmill inside your clinic. Again, what you want is you want a frontal view, both frontal views from front and back, and the sagittal view from each side. Typically, I film 10 to 15 seconds each. You don't have to film for a very long span of time, especially if they've been running for a while. But you want to be able to get at least 10 to 15 seconds of the shot before you turn the video off. Again, you want the full frame, the full body within the frame. And typically, I will have my runners run a leisurely jog that's at least 60 seconds, sometimes up to 5 minutes or longer, depending on what type of runner they are. And then I'll have them up their pace to more of a running style or a race pace or tempo run. Again, it needs to be more than 60 seconds, and it could be more than even 5 minutes, pending what type of runner they are. And then we'll do an interval or a sprint speed. So a sprint isn't typically a sprint like you would do for a sports athlete, like a soccer player or a basketball player or a cricket player. It's not a very short distance. It's more of like a 30-second sprint or something that would be more of like a 200 or 400 meter around the track. For a distance runner. So you want to be able to look at them at all these different speeds and see how their form changes based on the speed that they're running. All righty. And again, here's kind of a look at a couple different runners in different views. So again, the left-hand side, you'll see the sagittal view. We want to see from the head to the toes. We want to get them all the way in the frame. And then again, from the posterior view, the frontal plane, and then the anterior view, the frontal plane as well. So those are just a little bit of an example of all the different visual field you need to be able to analyze effectively and appropriately. Now, if we break it down, so this is now where we get into the what. So what are we looking for as we analyze our runners? And so what are we looking for in a sagittal plane? These are the big things that we kind of pay attention to, or that I pay attention to when I analyze a runner. The bolded things even more. So their strike pattern, what do they look like at initial contact? So here you can see me running. My initial contact is right here. You can see that would be what's considered a heel strike, a heavy heel strike, I would consider it. So you can be a heel striker, rear foot, midfoot, or forefoot. So you want to document where do they land on their foot as they first hit the ground. You want to measure their knee flexion angle both at initial contact and at mid stance, because those are going to tell you two different things. At initial contact, you want that knee flexion angle around 20 degrees or around 160 if you're doing an actual analysis on the screen, which I'll show in one of my videos. And in mid stance, you want that knee flexion angle around 40 degrees. So again, that's looking at for an overstriding pattern, is their knee really straight out in front of them as they land, which can increase their braking forces. Or are they landing more underneath their body? Are they landing very underneath and actually using more of their ankle and calf complex, which can bring apart its own issues? The tibial inclination angle will typically go hand in hand with the knee flexion angle. So if the angle is more up and down or parallel in space, then it's a little bit more underneath you. If it's more straight out, or I guess I should say straight out in front of you, then it would go along with a knee flexion angle that's too straight or decreased. Also, you want to look at their trunk positioning. So where are they in space? Are they leaning far forward? Are they upright? Are they leaning back? Typically, it's fairly normal to have about 5 to 10 degrees of a trunk lean forward. So that's another thing you want to look at. And then you want to look at hip extension, which can be tricky because hip extension, you have to make sure you're looking from the pelvis, not from the lower back. So that was a big mistake I made as a new grad physical therapist, is I was looking at hip extension from basically a vertical plane versus from where the pelvis was in space. And you'll start to notice that people have, at least in the United States, our hip flexors are typically very tight because of the way we sit. So you'll have to kind of adjust where the pelvis is in space and go from the pelvis to the hip joint versus the low back, or from a vertical plane to the hip joint. And I'll kind of show what I mean by that. And that's what makes that pelvis position really important. You can also catch someone's cadence. So cadence doesn't have to be anything fancy. If you're not familiar with what cadence is, it's how many steps you take in a minute. And you want about 10 to 15 seconds of a frame shot, because then you can basically, if you get 10 seconds, you count how many steps they take in that frame, multiply it by 6, and then you've got how many steps you have in a minute. And so on and so forth. So cadence can be pretty easy, and it's one of the most important things I look at in my runners, of especially those with knee pain. And you take 10 seconds of your time, count how many steps they take, and then you've got their cadence. Okay, so now what do we look at when we are looking at the frontal plane? So this is the frontal plane with a posterior view. And the biggest thing I always look for in this view is what's called contralateral pelvic drop. If you're familiar with this, which you'll notice in my video here, is that when I'm, let's see if I can move one thing out of my way here. Okay. Ooh, need to do that. Okay. So when I'm in mid stance, meaning my knees are right next to each other, and I'm standing on my right side, my pelvis on my left side is dropping down. And you'll actually see a little bit of a lateral trunk lean to the right to kind of accommodate that. And so that's probably one of the biggest things I look for looking at a runner from behind, and looking at a runner in general, because this is tied to a lot of different running issues: IT band syndrome, patellofemoral pain, plantar fasciitis, things like that. So it's a big problem, and it's actually kind of supported as a trend that we see, that people who have this type of gait deficit do tend to develop running injuries. So contralateral pelvic drop is one of the most important things I look for. Medial collapse, which is what I also call your knee window. So how much space you have between your knees. There should be a little bit of daylight between your knees as you're running. If your contralateral pelvic drop is really bad, it will narrow that knee window. If you have what's considered a dynamic valgus, so that knee diving inwards, it'll narrow that knee window. If you have significant overpronation, and it'll drive your femur into internal rotation, that will also give you a narrow knee window. So a lot of different things. Typically, the pelvic drop and the medial collapse are good friends. They kind of hang out together. You'll see both a lot of times. Crossover is something else we look for. This is tied a lot to IT band syndrome. And what you're looking for there is basically, does one side come across the body, or do both sides? And what that means and what we're looking for there. Other things I look at, pronation and supination, which is tough to see in shoes, depending on what the degree of the pronation or supination is. A lateral trunk lean, typically this indicates a compensation for a pelvic weakness or a hip weakness. Arm positioning, so are they really abducted? Are their arms really far away from their sides? They're running like they're trying to take off into flight. That a lot of times will indicate weak core control because they can't counter the motion of the pelvis. And your heel height. So I'll look at heel height basically and compare the two. Is their kickback or their foot coming up back behind them? Is it equal between the two sides? And that can indicate push-off capacity, hamstring issues or hamstring weakness on one side versus the other, things like that. This is the tool that I use that I encourage therapists to use when they analyze runners, because it is a really, really good breakdown of what you're looking at and where you kind of want your runners to be. So it takes something that can be a super overwhelming process and it breaks it down for you. So this tool, it's developed out of the University of Wisconsin by a famous physical therapist here in the United States named Brian Heiderscheit, who's a really, really brilliant guy. He's does a lot of running related research at the University of Wisconsin. I've seen him teach several times now, and he's amazing. So he developed this tool, and I use this for all of my runners. It breaks things down. It keeps you focused. It keeps you from getting distracted. And it's based on, a lot of research of trends that we see in normal mechanics and kind of what can be tied to abnormal and then therefore injury later on. Okay, so these are the three big things. If you're gonna look at a runner and you don't know where to start and you don't know exactly what to look for, these are, in my opinion, the three most important things to see or to look for and find out if you're seeing it, because these are the three things that are tied to injuries the most. Again, that contralateral pelvic drop, like I talked about. So again, if he's in left mid stance here, his knees are right next to each other, and that's where you want to freeze your frame when you video somebody. Is that right side, is that right hip dropping down from that vertical plane, which is represented by the dotted lines there. Then the medial collapse or the narrow knee window, which is the middle frame of myself. What you'll see there again is looking at it from the frontal plane, you'll see that hip adduction, adduction, so it's diving inwards and it's turning in or internally rotating. And that is creating a really narrow window of space to look for. And then as that knee dives in. And then finally here on the right-hand side, this is actually my colleague, Sim, who's running. And if you see here, you've got a fairly heavy heel strike, which isn't always a bad thing. A heel strike doesn't always indicate injury. The majority of, at least Americans, are heel strikers, and they do okay with it. But if it's correlated to an overstriding pattern and a really low cadence, and they're dealing with knee pain, and you feel like they're hitting the ground very hard, then that can be a big indicator of a gait deficit in terms of overstriding. So this increased ground reaction force that we can kind of expect to see in heel strikers can be problematic if the person is running and dealing with things like knee pain or things that are more bone stress related, like stress fractures, shin splints, issues like that. Okay, so that's pretty much all of the words that you're going to see today. Everything else is going to be videos, and we're going to break this down. I wish that I could kind of interact with the audience and have you guys answer back, but I know that that's going to be that's tough to do with the live. So I'm going to kind of pause, and if you think to, you can answer on your own while you watch this at home and see if you can pick up some of the things. By no means should you be able to look at a runner run and immediately know exactly what's hurting them. I have tried to be that person, and even after 4 years, I still can't do that. So again, don't overwhelm yourself with what you think should be happening or what you're trying to figure out. Just look at the runner and say to yourself, okay, what do I see? What am I seeing when I watch this person run? And then we'll go from there. All right. So first runner, the young gentleman, he's training for a half marathon. So this is him in real time, and then this is him slowed down a little bit. And if you see, what we're looking at is his initial contact. So as he comes forward and he lands, you can see he's got that heel strike pattern. May not be a problem, but I am a little curious because his initial complaint is actually left knee pain. And if we look at that and we draw that arrow in space, we want that angle to be about 20 degrees or about 160 degrees. So he's lacking almost 10 degrees of knee flexion at that initial contact. And his ground reaction forces, I use a sensor system, so I can cheat and know this a little bit. His ground reaction forces were somewhat high. So that was the biggest thing for looking at the sagittal plane for him, is when we watch him run, again, we can look again, we see that initial contact, a heel strike, and we see that knee flexion angle really decreased by about almost 10 degrees. And it correlates with what he's dealing with, which is knee pain. Other things he would maybe be dealing with could be things like shin splints, tibial stress fracture, stuff like that, or issues like that. But that's a good example of what we're talking about when we talk about that overstriding pattern. So when I look at a runner like this, I immediately want to go ahead and calculate their cadence, see where their cadence is. If it's a really low number, meaning something lower than 165, especially if they're at a running pace, I work on cadence retraining. And again, that would be something that we'd probably talk about in another lecture, because this is more about the what, not the how or how we fix it. But that's what we would look at. And he's a good example of that overstriding pattern that we see. Okay. All right, so our next runner takes a second for this video to start. But here we go. So now we're looking at her from a frontal plane, the posterior view. So what you look at here, or what you might see and what you might notice, is her right lateral trunk lean, especially in that mid stance phase on that right side. So she kind of hangs out, shifted right, but especially when she's actually having to put her weight on that side, we see her really struggle, and we see her really have to use her right arm to kind of propel herself forward. So this is a runner who's dealing with a fairly nasty case of IT band friction syndrome on the right side. Her right hip was super weak, looking at its abduction, even just in a manual muscle test, which sometimes can't be super reliable in runners because they max those out. But even for her hip abduction and her hip external rotation and internal rotation was fairly weak on that right side compared to the left. And you see here that she's basically having to compensate and bring her body over her hip because her hip can't stabilize her body in an upright position on that right side. So she's shifting her trunk over. She's using kind of the density of the IT band to give her some more stability, and she's getting some compression type symptoms. She's also got a little bit of overpronation on each side. I think the right was a bit worse, and she's got a little bit of crossover on the right side also. So those are a couple other things that you might notice when you watch her run. All right, so we're back to the sagittal plane. This is something that I'm not sure if I actually mentioned this in my slide or not, but this is something that's important to look for as we watch this runner run. So he's a little bit more of a rear to midfoot striker. If we look at him run, the biggest thing that jumps out at me is how much vertical oscillation he has, which is what's kind of being drawn on the screen here with this red line. So if you see someone running, and in this example, he was dealing with right knee pain and right hip pain, and he had a previous history of a left pylon fracture of his left ankle. But you see here as he's running, his movement is so much more up and down versus forward, which is one of the bigger things we look at it from the sagittal plane is this person not only adding more forces, because the higher you come up, the harder you come down. So you increase your ground reaction forces with that. And also you really start to lose your efficiency. So maybe this person isn't an injured runner, maybe it's more of a performance athlete, But if this athlete is trying to PR at their next marathon or compete in a competition, he's wasting a lot of energy coming up and down than he is coming forward. So things like with runners like this, I usually give them a visual cue. So I'll put a mirror in front of them and I'll tell them, you know, run normally. And then now think of yourself, see how much up and down movement you have. Can you glide? Can you glide like an ice skater versus bounce like a gazelle? Because you're wasting a lot of your time and a lot of your energy going up and down when running should be a forward movement. So that's what we worked on with this gentleman. It also can add some issues to things like the Achilles tendon, because you're asking a lot of the Achilles tendon to propel you up and down versus forward. And that can cause some issues for the calf complex as well. So a couple of things to look for in terms of vertical oscillation and excessive up and down movement. Okay. This is one of my favorite cases, I think, of my career. This gentleman is a 5K distance runner. He was actually hit by a car and sustained, I believe, a right femur fracture and a traumatic brain injury. And he had rehabbed for a long time, and he came to me with some right knee pain. And so this was I think his initial evaluation. And this is a really good picture of contralateral pelvic drop. And if you see it as it slows down, that right side, you can really see a nice big difference between the pelvic drop on this right side. Even if you don't have, you know, even if you can't see the PSIS or the hip bones, you can tell even just using his pant line that his left side is very different than his right side. And it's pretty common for people to get right knee pain when their hip is not stabilized by that right side. So again, as you watch him kind of running, you'll look from behind, you'll bring him into mid stance so that, again, the knees are right. So we did his rehab actually all remotely because he came to me. Hopefully this will keep working for us. He came to me right at the start of COVID and right before everything shut down. So we did all of his rehab via telehealth, working on hip control, starting with core exercises and non-impact exercises, and then going to single leg exercises with visual cues, and then eventually into plyometric and hopping exercises. And he really did quite well. He came back for about a 4-month follow-up into the clinic, and his pelvic drop had improved. It was still there, but it had improved. His knee pain was gone, and his ground reaction forces were significantly less. So he was one of my favorite cases because we had a bit of a time trying to figure out what to do since we were working all remotely. But he made probably one of the best outcomes I've seen and done virtually, which was really promising. Okay. All right, so this runner is a little bit more subtle, in my opinion, as to what kind of are we looking at and what's kind of going on here. So he was coming in for, I believe it was right hip pain and low back pain. And the low back pain actually would sometimes travel up to more of his like lower thoracic type area. So as we watch him run, what you'll notice, and this is more of a trunk rotation thing that we're looking for. So as he's swinging forward, he gets a lot of rotation to the right, and you can tell because his elbow is indicating that. His elbow is coming further back, but now as he tries to rotate to the left, he's really not getting a whole lot of rotation. This is a tricky beast of a situation because you don't know if it's that the right is moving or the rotation to the right is too much and that's what you need to control, or that the rotation to the left is too little and that's what you need to control. So this can be a bit of a tricky position to be in. But if we slow him down, what we found when we evaluated him is his right hip was quite tight into extension. So he wasn't able to actually get that sling system, so that as his right side was pushed behind him, his left side couldn't actually rotate as much as we wanted. And I thought he was going to have a really stiff kind of mid back, low back, and it was getting caught and not able to rotate, but it was actually coming from that right hip. He wasn't able to extend there, and therefore he wasn't able to rotate as much. He was kind of a combined issue because he was actually very flexible. His low back and even his thoracic spine was pretty flexible, and he was actually needing a lot of stability work to control his right rotation as well, just to kind of even out where he was in space. So for him, we worked on hip flexor, flexibility, hip extension, range of motion on that right side. And then we worked on controlled anti-rotation to the right to kind of even out the way that he runs. So he wasn't constantly hinging to one side and compressing that one vertebrae. I think a lot of his pain was here and a lot of his pain was here. So he was getting a lot of compression in these two areas. And that's kind of how we addressed that. But this case is a little bit trickier. It's a little more subtle. And a little more confusing as to, okay, we know what we see, but why is it happening, and how should we fix it, or if we should even address it at all? Alrighty. So this is an excellent example of, hopefully you guys can look at this and see kind of what I'm going to say here. A really narrow knee window, and it's happening for a lot of reasons. This is very typical for our teenage girls who are, a little bit weaker. They're going through growth spurts. Ligaments are starting to become a little more lax, or they may have a ligament laxity issue. And if you see it here, so you'll see that femoral internal rotation. Now we have to assume that because this is a frontal view and it's 2D, so we don't actually see rotation here. We have to kind of assume that there's rotation happening there, even though it's a 2D plane. What you'll see is here, she's really right underneath herself, and she's getting this internal rotation and this kind of valgus into the knee position here. So if we watch it one more time, and you'll see she even has to kind of push off, especially on that left side, from an internally rotated position. She kind of, as she swings through on that left, right there, pushes off. You get a lot of internal rotation in the swing back phase because she's having to push off from an internally rotated position. So there's her knee window, really narrow, no light between those knees. Her knees are basically touching each other. And again, that's because you're getting internal rotation really on both sides, on the stance side and here in the swing through side, as she's pushed off from an internally rotated position. So if we think about this is pretty telltale that we see this. This might predispose her to things like ACL injuries. This might predispose her to things like IT band syndrome, gluteal bursitis, things like that. What we would look at, and I think is important, again, not to really go too far into why is it happening, but something that I always encourage people to assess is when you see this much internal rotation or this much of a narrow knee window, you should really look at how much, you should get them on the table and put them in a prone position and check out how much internal rotation motion that they have, because I'm going to bet it's very excessive. And then to follow it up with a Craig's test. So looking at kind of eyeballing and seeing, okay, does she have any sort of anteversion? And is that playing a role in how she's running? Because if she is really anteverted, then you won't be able to fix that. You can still improve it though by basically building up your eccentric control of your external rotators and building up your hip strength there. But she may never look like a different runner has a full knee window, a lot of daylight, kneecaps are facing forward, knees not diving in, and you would basically be pushing her to be something that she's not if she is actually anteverted. So I always encourage people, when you see this much internal rotation, look at how much internal rotation they have in real life on the table. And if it's a lot more than external rotation, then do a Craig's test, look at her her anteversion, and see if that's playing a role, because you don't want to, you'll frustrate yourself if things aren't getting better, or if you're expecting more from the runner, when in reality they're actually made this way, and there's not a lot you can change in terms of the structural difference. So you've got to focus more on the muscular things that you can, muscular changes you can make for these runners. Okay. Here's a really interesting case. This is a gentleman who, if you can tell, his gait is very interesting, because it looks like he's working very, very hard to maintain the pace that he's running. And this is a really interesting case. He was actually being seen by another therapist for low back pain and for actually, I believe it was a stenosis that was impinging on his spinal nerve. And as you can tell, especially on that left side, he's really not dorsiflexing that foot. He's really not actually clearing that foot. And we had kind of a suspicion that the compression is getting to be too much, that he was actually almost giving himself kind of a foot drop here. And it wouldn't happen. You couldn't see it right away if you were just to test dorsiflexion on him. It was actually quite strong, but over time, as he was running, and if you can tell by his trunk position, he's not really leaning forward that 10 degrees. He's actually really upright, almost back a little bit. And that'll actually that'll cause that compression in that low back and that stenotic patterning to be worse. So if that's what he's getting when he runs, now you're loading in a high impact exercise like running on an extended spine that's already stenotic, and you're cutting off that nerve root to these legs. And that's why it looks like he's having such a hard time, because he is. And that's why I think you're seeing too this interesting foot issue on the left. Like, he can't really even dorsiflex to swing that foot through. So he ends up having to just kind of tiptoe and run through a plantar flexed foot. Whereas on the right side, you see that kind of, he's got the swing through. The left really doesn't do that. So this was a case where we were a bit concerned to have him keep running, because we didn't want, anytime you have a low back condition like that, where spinal nerve impingement is happening, you don't really want to be in some sort of upright position where the compression will get worse. And you definitely don't want to add impact to that compressed position as well. All right, so these are two different patients, but they are quite similar. I'll pause for you at home, and it could be like a game show for you. If I were to poll the audience, I guess I would ask, what do you think both of these ladies have had done? These are both post-operative cases, and they are the same procedure. This is, if you can tell, I kind of gave it away from the video, but also if you're watching, you can look and say, okay, well, it's the post-operative case, but what operation was it? No way you're actually going to know that, but it's very common. These are both lacrosse athletes, and they had both ACL reconstructions. And then you can look and say, okay, well, which knee do I think is actually the knee that is the problem? And if for both of them, it is actually their left knee. So as you see them running, you'll notice one, that they are spend a little bit less time on their left side. And also as they're running, you'll notice in the mid stance phase, which is why this mid stance measurement is important. Here in the mid stance phase, you'll see that her knee flexion angle should be around 140. So it gives you about 40 degrees of knee flexion. That's kind of where the norms are. And both these ladies, again, are about 150, 147. So they're lacking some knee flexion. And a lot of this is either because they are still really weak and they can't allow their knee to bend, because they won't be able to really absorb that force as well. So whereas on the right side, they're able to kind of bend through that mid stance phase, absorb that shock, but on the left side, when they're in that mid stance phase, they either don't have the strength to support a semi-flexed position of 40 degrees, or they may be too afraid to, which is another compensation that we'll see a lot is people don't want to trust their knee to go into a 40-degree flex position in a running phase. And that's one of the biggest things that we'll see with our post-op ACL surgical patients, is that this knee is typically much straighter, and it won't bend or absorb shock as well as the other side. Okay. All right, this guy again may look familiar to some of you because he was also a professor at the Walking to Running course last year at Sanchetti. This is my boyfriend, who is attempting to run. He has a very interesting running form, and I'm constantly baffled by it. So this is just us running in our neighborhood, and he was dealing with, I guess you could guess at home what you think he's dealing with from this very, very short clip. He was dealing with some pretty bad left Achilles tendonitis, tendinopathy when he was running, and he would even sometimes get like a numbness in his foot that would happen if he was running for more than a mile at a time. So to slow this down, we'll bring it over. Oops. Okay, so I first framed this because it's very difficult to see in the video, but this is a really interesting running pattern, because what you see here is you see this calcaneal valgus, which typically will accommodate or will go hand in hand with an overpronation. What I know about his foot that you guys don't is he actually really doesn't have a pronated foot. He has a very supinated foot, a very rigid foot that doesn't pronate really through the midfoot. It really just gets this calcaneal valgus thrust when he's in mid stance on both sides, but the left side is definitely worse. And the other interesting thing about that is if we look at him from the front, he's actually someone who runs on kind of a varus knee positioning. So if you look at his kneecap and where it is in space, it's actually pointing slightly outward. So we talked a lot about dynamic valgus, medial collapse, the knee coming inward, which you'll see a lot with, younger female runners typically. Well, he has more of a varus position of his knee, where his kneecap is actually going laterally, and he's landing and bringing his weight through a fairly unstable calcaneal thrust. And so this can be a big deal because the way he lands in his knee is not super accommodating for shock absorption. Varus knees are typically, the shock is a little bit higher when you run with a varus knee. And then he's having to basically have a higher impact on a more unstable subtalar joint. So what was happening with him is that he was getting almost these two things happening, a higher force on an unstable surface, and his Achilles tendon was just constantly getting thrusted into a bad position because of where his calcaneus is going. He was also really trying to work in a shoe that was not fit for him. And he was working through, he had tried to do kind of the minimalist running movement as well. And that didn't work super well for him either. And so that kind of what made it worse. But this is a really interesting combination that I don't often see. Typically you'll see this pronatory, this kind of assumed pronatory collapse because it looks like someone's pronating based on their calcaneal valgus. And then you won't often see that varus knee. You'll usually see the internal rotation and almost a valgus knee following that pattern. So he's a really interesting case that I wanted to include here. This is another interesting case, so interesting that I thought we should look at him from both the frontal view and from the side. It's a bit tough to decide, okay, well, what's actually happening, and he was really, really interesting to see in real time. So this patient, if we look at him from the frontal view, you can tell that there's a little bit of difference in terms of where one knee is, and it's hard to see, I apologize for that. But his right knee almost seems like it kind of comes across his body, or his right leg kind of comes across and almost not quite circumducts, but kind of swings around, whereas left kind of comes straight through. If we look at him from the side here, you'll notice his foot strike is similar, but it is not the same. So you'll see on his right side, he's landing midfoot. On his left side, he's landing very, very forefoot. So he's basically running on his toes. This is an interesting case. So one thing you would want to look at for a patient like this is their leg length and their leg length discrepancy, because if you have someone who has a fairly significant leg length discrepancy, they will have to land in a more forefoot running position to accommodate a shorter leg, and then they will have to kind of swing through the longer leg. And this is what this case is. He was actually a previous patient from a long time ago that had undergone limb lengthening correction surgery because of a congenital bone deficit. So he actually never got fully corrected. He decided he didn't want to, I think he had decided that he wanted to not do the last, I can't remember what the deficit was. I want to say somewhere around like an inch or so. He decided he didn't want to go through and have the surgery. It's a pretty cumbersome surgery that takes a lot of time and a lot of PT. And it's something that we specialize at the hospital I work at Sinai. And so he decided to keep the leg length kind of difference. And this is kind of how his mechanics looked because of that. So you may not have someone who has a congenital deficit. It may be more of a functional leg length discrepancy. But here the difference is so apparent that you would want to see, okay, you would actually want to get your tape measure out and measure, even though it's not the most reliable test, get an idea of, okay, this looks like there's a really big difference between the two. And again, if it's a structural deficit, like in this case, then you're going to have to accommodate that. There's not going to be a muscle energy technique that's going to fix this because it's too big and it's structural. So then you'd have to accommodate it with something like a lift for his shoe. And again, that's important to know, okay, what am I seeing? And then investigate, why is this the case? So looking at his actual leg length difference. Is this structural? Is this functional? And if it is in fact structural, how do we fix it? And do we fix it? And in this case, I would add the heel lift to give him a little bit more height on that left side to kind of even that out. Okay, I realized that I put this slide in for questions. I don't know if people will be able to ask questions, but if we do have some questions, or if you have questions after watching this, this is my contact information. This is the website of our running program at Sinai Hospital. You can see kind of a little bit more of what we do there, what we do in terms of gait analysis. So what we went through today was all video gait analysis and 2D analysis. I also use a sensor system, and I have a little blurb on there about how we use our sensors and how we correlate those findings for our running patients. You can also reach me at email. It's my Gmail there. So you can reach out to me with questions there or any feedback you might have. And I'm also on Instagram. This is my professional Instagram account. It's used as a resource for a lot of students, PTs, runners. A lot of the slides or the pictures and videos that I use today, I also use there. So I try to post some things about different gait deficits and what we're looking for, so that people can just be able to see more and more runners, even if they're not their own patients, to get more familiar with gait analysis. So that's all. I think I just have my reference slide, which I should show. Yep, so those are my references. If you are watching this, I do ask that you not reproduce it or that you not share the videos. They are, patients have consented really just for me to use them. So I'd appreciate if people wouldn't reproduce the videos of the patients and really use them just for self-study. But yes, Sid, I'm complete with my presentation. And there's a nod.
Yeah, hi.
Hey.
So yeah, that was a great presentation, and 2D analysis really helps. And to just start off, and there are a lot of clinics considering these options in India as well. So that really helped your presentation to start off with some analysis, because 3D can be quite quite, once quite difficult to do, quite difficult to calibrate the equipment. But this is the 2D analysis really, I feel, is a good start to running analysis.
Yeah.
I just had one question in my own clinical practice. What I have been seeing is a lot of patients complaining, or rather, a lot of obese patients wanting to get into running.
Mm-hmm.
And it's sometimes I tell them to first work on their body composition, get down on their fat percentage, and then consider it. But how do you go about doing it? Because I see them getting injured a lot.
Mm-hmm. Yeah, so that's a great question. We have a lot of the same struggles, I would say, in our clinic. What I actually do, we have an AlterG, which is basically a gravity assisted treadmill, so that the patient can zip into the treadmill and actually lift them up. Now that's a really nice fancy piece of equipment that I have, that I get to use, so that it actually decreases ground reaction forces in joints, and it can basically offload some of the extra weight that the patient has. Now I understand that's a luxury that most other clinics don't have. So what I do with these patients is typically I start them, I recommend the same thing. I recommend that they see a dietitian in terms of working on weight loss goals. And I start them on a run walk program that's very heavily walking oriented and then minimally running oriented. And for these patients, typically I will recommend, a little bit more of a supportive shoe. Typically shoe recommendations aren't a big thing of mine, but that is one population. I want to make sure they've got a good supportive shoe because of the extra weight, and I want them to ramp up slowly. So I usually come up with a specific program for them that is time-based, and it's to be done every other day, and it's basically a walking, running program. Other things that I'll encourage them to do in order to help lose the weight in order to prep themselves for running is encourage them to do something like the elliptical or cycling, so that it's not as much impact, because we know that your ground reaction forces are high when you run, especially at the patellofemoral joint. And then if you're looking at someone who's 30 to 50 to 80 pounds overweight, that that 3 times your body weight is significantly more on that joint. So I always try to kind of break it down as, this is kind of why we don't want you just to be unleashed to run. We want you to kind of lose that weight. It's frustrating, I think, for the people, and you have to be sensitive about the conversation, is likely they're trying to run in order to lose weight, and then they feel like they're in this cycle of, well, I'm overweight, I want to lose weight, I know running will help me do that, but you're telling me that I can't do it safely. And so I try to meet them somewhere where we can do a joined running walking program, and we can give them some other alternatives and other resources, so that they can really prep their body to become a runner, even for a little bit further down the line once they've lost some of the weight.
Right. Thanks a lot. That really helped. The other question, a small question, what I had is, do you find a big difference in doing your analysis on the treadmill and on the road? Actual analysis where you can do a real-time analysis. So do you find a lot of difference in both these analyses?
That's a really good question. So in terms of the video gait analysis, which is what I talked about today, it's somewhat difficult to do it on the road, because obviously the person is only in one, they're running kind of past you and then they're running away from you. You really cannot get an effective sagittal plane view with someone doing overground running, unless you had some sort of fancy, cart going alongside them to get them in real time. But you can't really have them run past you and see a consistent over and over again trend that you see on the treadmill. So I will say, overground running, I can typically get a pretty decent view of the frontal plane from the front and from the back, but I can't see a good sagittal plane. So if the person is able, if I have access to a treadmill, and if the person is is familiar enough with the treadmill, I typically try to prioritize a treadmill assessment for the video gate portion. Now, I also, like I said, I use sensors. So the sensor system can actually be taken on a run and you can look at data and objective measurements, but you really need the video to correlate what that data means in terms of how it's coming into play with their form. So I always prioritize the treadmill assessment. I wish it didn't have to be that way, honestly, because so many people are much more natural over ground. But I do prioritize the treadmill assessment. I do give them that 3 to 6 minute acclimation period so that ideally their mechanics are somewhat similar to what they are over ground once they've acclimated to the treadmill.
Yeah, over to you, Siddhant.
Okay. Yeah, I have a few questions for you as well, Annie.
Sure.
Yes. So the first one is, you spoke about the app, right? So that you generally recommend your patients and the people you interact with to download. So can you just talk about that app quickly? Like how can...
Yeah. Yes, I meant to actually be more clear, but so there's a couple of different systems you can use. The system I use is called Huddle Technique. In fact, I can pull it up here. So the icon, if you look for it in like the iTunes store or whatever, I hope that it'll show. It's kind of an orange like timer system. And that's the one I use. It's HUDL, Huddle. And you can get it for free. There's an elite version you can pay for. I've actually never had to pay for the elite version. I can use pretty much I use all the features I need to through the app itself. There's a couple other ones called Coach's Eye and Dartfish, I think. So those are other platforms you can use. Huddle has been the one I've used pretty much my whole career, and you can slow things down to 1/2, 1/4, 1/8 speed. You can draw on it, you can record it, and then send it to the patient or send it to the patient's physician. And I think now you can even save the video to your camera roll and incorporate it into things like this, like lectures. So I like the Huddle Technique app the most from what I've seen.
Yes. And thank you so much. And the second one goes as, now when you were back in India last year, we had a discussion about the barefoot running, the minimalists, and the proper running. So that was a panel discussion. So now the videos that we have seen, actually, they are almost everybody, correct me if I'm wrong, like almost everybody were in shoes. So how do you actually deal with the minimalists or the barefoot runners when you're analyzing them? So do you really take them directly on the treadmill without the shoes? Because I don't think that's recommended. So
yeah, that's a good question. I will say I haven't had a whole lot of barefoot runners come in. For the ones that I have had, or the ones who are more minimalist, they typically will wear their minimalist shoe for the assessment. So like, there's a shoe called like a Vibram 5-finger shoe, which is basically like a sock that you wear, a rubber sock. So they'll wear that. I have had people do walking assessments barefoot on the treadmill if I want to be able to see their feet. And we also have what's called a foot pressure system. So when we make things like orthotics or we do running assessments and we want to see their foot pressures, that actually has to be barefoot. So I'll use that system as well. The problem with that is so many people aren't barefoot runners that running barefoot just simply for that assessment kind of throws off their form, and we're not quite sure if it's really accurate to what they look like in a shoe. But to answer your question, yes, if they are a barefoot runner, I will have them on the treadmill barefoot. I just very rarely see that. I don't know if I've ever had a true barefoot runner come into the clinic. I think I've just had someone in a very minimalist shoe. So I would have them run barefoot if that's the way that they run in real life.
Yes. And the last one from the audiences was, you spoke about the pathological drop, right? You spoke about the pelvic drop, right? So how much degrees are we actually talking about to actually be a pathological drop?
Yeah, that's a great question. And if I go, let me see if I can go back here real fast to this tool that I use. And I think it's typically 5 to 7 degrees for females. And hold on, let me double check before I say something wrong.
Yes, I think so. That was the one.
I want to say it's 5 to 7 actually for men. Ooh, got a lot of videos. There we go. So this is a nice little cheat sheet, but yeah. Okay. So for typically it's 4 to 7 degrees for females, which you'll see here, and then 3 to 5 for males. Okay. I would say I get really nervous, especially like the 10 to 12 range, which I have seen that. So, typically males will have a much less pelvic drop because of the way the pelvis is more narrow and more supported. Your Q angle is so much shorter and smaller than females is. So that's why there's that discrepancy between males and females.
Yes. Okay. Thank you so much. Yes.
Of course.
So it's always fun and honor to listen from you. So thank you, Annie, for the fabulous talk. It's really great to hear from a dedicated and ardent runner like you. And especially thank you for taking out time for this session for us. I would like to thank our panelist, Dr. Anand Gangwal, for his time as well. This wouldn't have been possible without our super enthusiastic Physio TV team, which includes Dr. Ashok Sham sir, Mr. Rahul Chaube, Dr. Apur Shimpi, Dr. Neeraj Athavale, Dr. Sona Kolke, Dr. Manish Ray, and all the other members of Physio TV. Lastly, a big thank you to our viewers for all the support. This is Dr. Siddhant signing off. Thank you once again. Stay safe, everyone. Bye. Bye, Annie. We shall be seeing each other soon again, hopefully.
Yes, I hope so too. Thank you, Sid, so much for hosting, and Anand for hosting and everything, and Sona putting it together. I appreciate you guys.
Thank you, Annie. It was a great session.